Hello, everyone, and thank you for your attention. My name is Kelsey Eaton. I'm one of the DMC ENT residents. I worked on this project with Doctors Nathan Gonick, Jamie Snell, and Kelly Levasseur, who are all attendings within different aspects of Children's Hospital of Michigan difficult airway care, including the ENT department, anesthesia, as well as the emergency department. This had really been inspired by multiple sentinel events in which there were uh, undesirable outcomes or unforeseen challenges or challenges that really should not have arisen within what is a very time dependent process and one that can quickly decompensate into more difficult situations. Now, to define what's a difficult airway, you essentially can break it down into three scenarios. One is difficult mask ventilation, in which the bare minimum of your airway intervention from an emergent standpoint is maintaining that ventilation status without introducing any foreign airways. The next one is the difficult tracheal intubation, whether that's either being able to visualize that glottic inlet or due to some sort of stenosis, which is preventing passage of whatever you are utilizing. The last one is that you can't intubate and can't ventilate. It's the combination of the prior two, and this then becomes a surgical emergency in which that ENT is often involved to obtain that airway. Now, it's important to realize that pediatric patients are not just smaller adults. They have different physiology and different requirements and just different challenges than you would predict with an adult, both from an anatomic standpoint as well as in combination with those physiological statements. They can desaturate in a quarter of the time as an adult. They have a higher metabolic rate as well as an increased heart rate that can contribute to this. And that oxygen consumption is 6 milliliters per kilogram within a minute versus just half of that of an adult. So they have a quicker desaturation rate as well as that direct oxygen consumption as well. Now, visualization can be difficult secondary to congenital differences than what you would deem a quote unquote normal airway. And some of these can be expected based upon just immediate assessment of the patient, whether that's micrognathia or a tumor, etc. But some of these can also just be entirely unanticipated and you encounter once you are attempting to visualize the airway. And then sometimes it's unclear as to why this visualization is so difficult. Now, as you attempt to place an airway, edema can quickly set in for these patients, and that can lead to quickly occluding what was maybe a minimally or partially patent airway at that time. Keeping in mind that our level of resistance is the radius to the fourth power, and so changes in that radius are drastically going to change the amount of resistance and subsequent difficulty with ventilation or spontaneous ventilation. Lastly, it's important to realize that a lot of these kids are new to this world or have limited history or have never had any sort of airway intervention up until this point. So the knowledge of what their airway status may be markedly different than that of an adult. Some of the main issues with a pediatric airway is that it is located more anteriorly, which can create challenges with standard visualization, and you do need often specialized equipment. The size of the mandible to that laryngoscope or airway stenosis or atresia can certainly affect those instruments that you can utilize and what tubes are maybe utilized or available to you. And from a structure standpoint itself, small mandibles can be very challenging, both from a retrusion standpoint and essentially falling over to the area that you normally be able to visualize the airway, or just to be able to fit in a laryngoscope can be a challenge and require specialized laryngoscopes for visualization. Clefts can certainly create challenges. The angle of the actual glottic inlet is not at 90 degrees. Unlike that in an adult, and they can be angled at an inferior direction, which can also make passing that too difficult. And then you have the situations of congenital masses, whether that's cysts or tumors, lymphovascular malformations, or hemangiomas. So what are the goals of what we were trying to achieve? And that was to truly discuss these sentinel events in detail and the challenges that occurred with them. And based upon that, perform a root cause analysis that would allow us to have actionable change that would then promote airway safety for these children. By actionable changes, that means ways that we are able to reduce emergent airway events and increase the management safety of those active airway events, and hopefully improve communication strategies for management of future issues so that people are more prepared and able to enact interventions more smoothly and faster. How we did this is that we developed a multidisciplinary team, which included multiple attendings and residents, and that was made up amongst anesthesia and otolaryngology, as well as the emergency department. And we discussed these sentinel events, the difficult airways, and what were the challenges that occurred. And then a root cause analysis was performed of these events. The root cause analysis revealed that awareness was a huge issue for these difficult airways, and understanding what it meant to have a difficult airway for that child in particular. And often either the ENT team was unaware, ICU was unaware of the difficulty, or anesthesia, and there was limited ability to be able to understand quickly what the issues were. So this also changes post-extubation planning, and then the actual intervention itself, having instruments available and those being consistent, as well as consistently available in the same area of the hospital to allow for these to be utilized in an expeditious manner. So to start, we wanted to improve awareness and worked with our EHR designing colleagues to be able to have a difficult airway tag present at the top of a chart if that ICD-10 code was being utilized in that patient's chart. This is automatic within the pediatric hospital, that if you open up a patient with that ICD-10 code, you will see that difficult airway present. We also created a list to be able to maintain knowledge and awareness of the difficult airways that are considered particularly challenging, and that is managed by the otolaryngology team. And then we wanted to be able to provide a communication template of what truly is difficult about this patient's airway and how it was addressed. This is an example of that standardized chart, which is available under the difficult airway within the power chart, and really lists what's the challenge about from an anatomical standpoint and how that airway was visualized and who needs to be present for that airway. Standardizing the equipment, we created a mobile unit that was meant to address pediatric difficult airways. It involves flexible scopes, rigid bronchoscope attachments, wide scopes, anterior commissural laryngoscopes for those small mandibles, and it allows us to essentially bring consolidated OR equipment to the bedside, particularly with laryngeal suctions and some of the more specialized equipment that's necessary. And importantly, it has contingency planning, including pediatric tracheostomy sets should a surgical airway become required. Here's a brief example of some of the equipment available. Lastly, we also started to do multidisciplinary education and sustainability training, in which scenarios were discussed amongst multidisciplinary teams. Now, directly observing airway events is difficult to standardize, and people are going to have different variants in regards to their ability to attend to these and intervene based upon skill level. That makes the standardizing the results of the study challenging. Thus far, the utilization of the airway cart has promoted subjectively expedited attendance, as well as streamlining the intervention, and communication has been markedly enhanced with standardization of the airway descriptions. Difficult airways are an inherent part of providing tertiary pediatric care. These assessments and interventions have allowed for improving the awareness and ability to communicate among care providers, allowing for improved planning and safer situations for patients and their families, as well as allowing for improved intervention strategies and being able to specifically design plans and care appropriate for that child. This standardization of equipment has allowed for being able to rely that equipment will work and be readily available, and has allowed for improved time management of these cases in which seconds truly matter. To conclude, awareness, preparedness, and consistent equipment are integral aspects of caring for pediatric difficult airways. These are situations that change rapidly and need to have the utmost amount of preparedness that is available in issues that often preparedness is not an inherent aspect of their care. Thank you for listening to this important conversation as we continue to try and provide improved care for our patients. Thank you.